Thank you everyone for coming, Breakfast at Sky. So this morning we have Jeanette Edwards from Shared Health, and some of you may know Jeanette as one of the co-chairs of the Sky Intersectoral Working Group with Cheryl. So she's got a real soft spot for us here at Sky. So she is here to tell us what's happening with Shared Health and to let us know about the scope of the project and the timeline of the project, because I know a lot of people have a lot of questions about what's happening and what's going to happen in the future and how it affects us and what the plan is. So Jeanette is here to fill us all in. Thanks, Jeanette.
Good morning. It's great to be here, but of course, after leading Sky for 17 years, I'm always glad to be here. First, I want to preface this with the title, Working Together to Build a Provincial System. And many of you remember the Sky Capital campaign, Together is Better. And so the first thing I need to say is you're all sitting here saying, what's the provincial plan? How's it going to affect me? And I think you need to sit back and watch because you're the leaders. So in fact, Sky was about system redesign. And if you think what you as a collective and all the partners of Sky have done, the building is a concrete structure, but more importantly, for 17 years, we worked at changing service. We worked at integrating based on people. We worked to find the most cost-efficient ways. Who would have thought that really there's only a couple of additional staff with this building? It was a coming together and changing how we work. So I need you to sit back and recognize that the partners of Sky have actually led the way. And if you think that the provincial planning is going to change everything you're doing, that's not going to happen because you're there. So that's my comments to start with, because I do believe that sometimes in all this world of change, we have lost sight of those who have led the way. And certainly Sky partners have been changing for years. So truly I've used Sky and the Sky partnership and the work that people have done and the work that's now going on really looking at our Indigenous population, engaging First Nations. You have set the pace. And so sit back and contribute and lead rather than be fearful of what's coming. System transformation, so some of us have been here for a long time in healthcare and feel that, boy, we've gone through changes. So we've gone through health advisory networks years ago. You've all heard, I'm sure, about Connie Curran and all of those changes. This one is massive. And it's moving quickly, and as much as change is difficult, some things are really exciting to watch as they unfold. The real issue behind this is how do we make sure we continue to have a health system? Healthcare is so important, but it is so expensive. So we are spending $6 billion in Manitoba alone. So imagine what we could do with that much money if we just sat back and realized what's going into the coffers in healthcare. We've got study after study after study, and this reminds me of going back to the history of Sky. I don't know if many of you realize that really Sky was because Rehab Center for Children was falling in the river. And that sounds so silly, but there was a crisis in the making. And there were a few of us that sat back and said, are we going to focus on the building or are we going to focus on service? And no different than today, in those days, there was a stack of reports. Postal report, families have been interviewed, Department of Education, Department of Families, all of them talking about the need to integrate services for children with special needs. And so the building falling in the river was the beautiful catalyst to say, let's stop and look at what people are saying, what we need to do before we think about the building. And I think that you'll see that that is happening now. We have had so many reports and studies, and over again, the same message. This really does remind me of children with special needs and services. All of the studies have talked about how complex our system is. Every meeting I come here and I meet with clinicians, it's about navigating the system. So you're talking around the population that you serve, but if you think about the entire system, it's hugely complex, and that complexity is acting as a barrier. So, and I have made sure that there are ongoing websites in here for you to go to. The cost curves are quite interesting. So in this slide, you'll see the red line is Ontario, Manitoba is the green one, British Columbia is the blue one that blends in with the red. But what it's showing you is the cost per capita. So we started off in 2002, 2004, still higher than the other provinces. So that's the spending per person. If you watch over the next decade, you see that those costs per person were escalating in all of the provinces, but we're beginning to level out. Here's what has happened in Manitoba. So it's just to give you a sense that the costs that we're spending on every man, woman, and child in the province has continued to escalate. So the real question in this is, how do we sustain a health system? And the bigger question, is there a better way to do things with that money? When you look at that cost per capita, we also look at CI data and so on, and we aren't the best for spending the most. And in many cases, we're falling behind and we're not keeping pace with other provinces. Certainly in some areas we are, but in some areas such as wait times, and you hear this on the news, for all the money we're spending, we're not getting the same outcomes. Stepping back, and some of you may have seen this slide, but it's really an opportunity to pause and think. So we're spending provincially $6 billion. So it's pretty close to half of the provincial budget. Dr. Coastal one day said, you know, the health system has an insatiable appetite. And he one year asked for proposals, and the proposals that came in were more than the entire provincial budget. So we could have no schools and no roads and just keep funding healthcare. Or we could sit back and talk about the health of the population and how do we redesign this. So I'm telling you all of this because I think you're waiting to see what the plan is. This is a fundamental system redesign, just as you did with SSCY. So if you look at this, you'll see the population by region. So you'll see that WHA, in the Winnipeg region, we have 57% of the population. But remember that as you then go to the north with 5.7% of the population, the burden of illness is higher. So although we can look at the actual numbers, we also have to look at access, the challenges to remote communities, and the burden of illness, the impact of social determinants. You'll see 75% of our population in Manitoba is urban, 25% is rural. These numbers may be also of interest to you. First Nations, 114,000. And then we also have special care populations. So you can see by this, we have a growing population with chronic illness. We have a high proportion of Indigenous people. We have all sorts of things to consider when we look at the impact of the social determinants of health. Then I want you to think about how big this is. So we've talked about 6 billion, but we also have more than 55,000 employees in healthcare. So think about SSCY and the change you've gone through, and now think about what change means in some of the things that we're talking about as we're moving forward. The complexity of the system is noted on the right side of the screen. But again, you'll see that we've got various funding departments, we've got various health authorities, or you'll hear the term SDO, Service Delivery Organization. So that includes the regional health authorities, Cancer Care Manitoba, AFM, and others. So if you think about all the different people who are responsible for component parts. So the challenges. So what is it we really need to stop and think about? So you see how much money we're spending. You see the complexity of the population. And here are just a list of the major issues. Fiscal sustainability. So how do we sustain delivering services, and how do we actually improve our outcomes? Equity is a huge challenge. And when we say equity, it's about equity to access, it's about equity across populations, it's about racism, it's about all of those issues. And so we need to look at that and remember that everything we're doing is provincial. So equity means not just within the perimeter, it's rural, urban, northern, and remote. Indigenous health. We're clearly needing to pay far more attention to Indigenous health. So all of these issues, and I'll describe for you some of the teams that are together. And it is about Indigenous health and with our First Nations people. So this isn't about planning for, it's about a truly different way to collaborate and taking a look at TRC and all of the areas we need to move in. Mental health and addictions as being a major issue. Up until now, those have been two separate component parts. Many of you have heard about the Virgo report. If you haven't, it is online and posted. Clearly a need in this province to rethink mental health. We do not fund mental health nearly as well as other provinces. Our services are terribly fragmented, and you have now seen already that we are talking mental health and addictions. Addictions is not separate or in a separate swim lane to mental health. Emergency services and EMS, you've all heard about as well. You tend to hear mostly about wait times and so on in Winnipeg. A very complex issue. We have many, many emergency rooms in the province. Some are open on Wednesdays, some are open Tuesdays and Fridays. And you can imagine that we really haven't paused and said, what is emergency? What should Manitobans expect in terms of access? And how do we make sure that access is equitable? And then there's the emergency services. So that is now becoming provincial. So that's all of your emergency transport. You've been reading about Lifeline, fixed wing, rotary wing transport in and out of Winnipeg. How do we redistribute emergency? How do we capitalize and maximize the use of fire paramedics? All of that is in that bundle. Home care and community. So there's been reports on this too. I'm sure that as I'm saying these, you can all recall hearing about a report. So Taves did the home care report. Home care does not exist in parts of our province. Home care does not have standards. So there are different levels of home care between each region. And home care has functioned as a service silo. And what are the opportunities to bridge that in so that truly we're functioning as community teams? Maternal health, another big challenge for us. Birth rates are going up. The number of deliveries in Winnipeg are very high. And our First Nations communities are really advising us we need to rethink about repatriation of maternal health back to communities. We are removing mums and babes for the last period of the pregnancy to live in Winnipeg. And if you look at what is most culturally appropriate, and I would say for all of us, it's about communities. And so to rethink maternal health. Palliative care, your specialists predominantly are in Winnipeg. And so how do we start looking at palliative care and ensuring that that is also accessible throughout the province and the supports are there? So those are a few of the challenges, and there are many more. But the reason I'm showing you this is to really point out that this is not about a plan at this point that is telling everybody what to do. This is about system redesign. So Jesse said when she looked at my slides, well, can't you give us more detail what's going to happen to us? And so that's why I started with, you've already done it. Now we're changing the system around you. So let's look back to what happened. And I think we need to pause and think about the amount of change that's occurred. All of these changes are good, and we're now ready to move forward. So some of you are old enough, you remember regionalization, and that was a great hoo-hurrah. So if you recall, many boards disappeared, and people were merged into regions. And we started with 13 regions. In Winnipeg, we had 2, the Winnipeg Community and Long-Term Care Authority and the WRHA, that merged. So this was the first move across the country, not just Manitoba, to really restructuring healthcare and starting to plan more systemically. And we, in 2012, started merging regions. So you remember that we went then down to 5. This too was occurring across the country. So many of you remember that, and some of those regions are still really going through all of that change and bringing 2 large organizations together. So today we've got major service delivery organizations. We've got 5 regional health authorities. We've got Cancer Care Manitoba. If Diagnostic Services Manitoba was a separate organization, we dismantled DSM, not the service, but the corporate structure, and actually used that structure to build Shared Health and Addictions Foundation of Manitoba. So in fact, in Manitoba, we did not add an organization. We started some of the restructuring. There was an earlier comment, just as I was waiting, and there was a comment about, well, all the other provinces were waiting to see if this was going to dismantle everything and put everything under Manitoba Health. So many of you are aware, Alberta did this years ago. They dismantled all the regions, and it was all the Alberta government, Alberta Health. They quickly pulled the pendulum back a bit and structured zones. So instead of having a lot of governing bodies, they still only have one, but their organization is by zones or geography. So you still have to pay attention to what's going on in local communities. Saskatchewan this year dismantled all of their regional health authorities. So there's still teams in each of the communities, but all is run by Sask Health. Nova Scotia's done the same. PEI did years ago. Ontario is now truly moving towards regionalization. So the question often has been asked, is that where we're going? What we've done in Manitoba is unique, as we always do in Manitoba. And we've created Shared Health, which is exactly that. It's Shared Health. So people envision a big building with a lot of staff. Up until last Monday, there was about 9 of us. So Shared Health is about pulling people together to plan. It's not a new structure planning for. It's creating an organization that truly is bringing people together, so we're planning together. Last week, you've started to see provincial services move to Shared Health, and I'll talk a bit about that. So Health Sciences Centre is now Shared Health. So rather than WRHA being so big, WRHA is going to start looking like other regions in Manitoba, operating the service delivery for the community. Shared Health will be supporting all of those regions, but accountable for provincial services. And the real need for this is to make sure that our provincial services are seen as provincial, not Winnipeg. how do our provincial services support our other regions? So if you hear me saying SDOs, it's just the new acronyms, here's what we're talking about. So what is that shared health? And so like I say, if you think there's a big building, not, we actually just took over about 5 offices that Manitoba Health vacated, that this truly is a facilitatory type of approach to planning together. So our responsibility at Shared Health is to lead the planning and the coordination for the clinical and preventive services plan. So you will hear CPSP. So that truly is the clinical and preventive services plan. That's our primary, that's being a huge piece of our role right now. And that planning isn't operational planning. So if you're looking for what's going to happen to me in my job, that's not what we're planning. We're planning system redesign. Shared health is a curious beast, so that's our primary role. But you are going to see shared health having a secondary role that isn't the lead and coordinate role. It will be the service delivery role. So now that Health Sciences Center, all of the lab is now provincial. So instead of being provincial plus Winnipeg, it's all provincial. Those operations are also part of shared health. So think of shared health as having this lead and coordinate function, and then the same function as all the regions, which is the service delivery. So there's operations and there's planning. So I think that that's sometimes confusing, and for ourselves, making sure that we are very clear. We are accountable to Manitoba Health for the service delivery that we're responsible for, just the same as all other regions. So other regions don't report to Shared Health, they still report to Manitoba Health. The vision, why did we start this? So some of us were really thinking about this a long, long time ago, is really to make sure that in this province, we do have an integrated health system. So up until now, every region did its own planning. Everybody planned in isolation, and we'd submit our plans to Manitoba Health, but there was never truly a forum to talk about an integrated plan. So when we talk about reducing wait times, we can't talk about that one region at a time. We are a very small population, and how do we look at system design? We talk about access, we can all talk about what we know, but how do we look at access provincially? How far away should people be, or how much time away should Manitobans be from emergency? So in Winnipeg, people get concerned with the emergency rooms. It's going to take me 9 more minutes to get somewhere. I'm now worrying about people who live in remote and northern communities. What is emergency? What does the access look like? The other thing that we're really going to be working on all of this is to decrease variability. What should standards be? If you have a hip replacement in Winnipeg, those same standards should be in Brandon or anywhere else where there's hip replacements. So really moving from planning to clear standards and how do we move forward. And I will just put my personal plug in here that this really is about quality. So right now we're in the middle of the clinical preventive services planning, and I'll talk a bit about that. We are also delivering provincial, so tertiary clinical services. So all of that started happening last week. So that's 12,000 employees are now shared health employees. We're all in the same benefit plan. We're all in one province. So it's really just transforming and getting all the SAP and the cost centers and stuff that don't make me a happy person just because too much detail. We are focusing on how do we tighten up our administrative support services. So for example, legal services, we had a large department in WRHA. No other region has access to legal services unless they contract them. So some of those services are going to come into shared health. So we're in fact supporting all of the other SDOs. So it's not just a mothership, it's everybody has equal access. The same will be happening. There's large projects going on for logistics, for purchasing. Where can we actually find efficiencies by doing these things together? Provincial health workforce, Beth Procre is leading that. Many of you know Beth was the Associate Deputy Minister with Health. All of the union rationalization, I know that you're all aware of that. This is something other provinces did before they regionalized. So this one is been a long time coming, a lot of change, but you will see the number of bargaining units become smaller so that we have the ability to function as a system. And quality and safety, I will briefly mention because we are moving forward on a much more detailed plan on quality so that, and again, you guys are way ahead, but really taking a look at what does quality mean in Manitoba. So the Clinical Preventive Services Plan, the principles are patient-centered, sustainability, equitable, access, appropriate, and we must preserve and in some cases enhance the quality of care. You have seen in the paper and on the news numerous reports. We're not starting from scratch. We're taking all of that information, just as we did with SSCY and services for children and youth. So we've had the EMS report in 2013. There's a big report on information technology, information management, 2015. TAVE's report, 2016. Most of you know it's also online that Peachy report started taking a look at the clinical services in Manitoba. So Dr. Peachy finished that in 2017 and still doing a bit of work. So that's really the clinical pieces. KPMG, all of you heard about that report. That was also 2017. That's also online. You'll see many, many recommendations in there about the inefficiencies and the complexity of the system. You saw the wait times reduction report focused on emergency rooms. Dr. Alex Chachinoff and others did that. And the mental health and addictions report is no longer pending. That's done. That's Virgo report. So think about it. We've got reports on reports on reports, and we now are going to move forward and look at all of those and develop a plan. So why do we need a provincial plan? Findings from Dr. Peachy's report, and the same was reinforced with the KPMG. Care is not well coordinated. As I'm reading these, think about how much SSCY has done, because I think you'll see now why I'm saying folks with SSCY, the partners, the thinking, the work, and it's not that it's finished, but you are the leaders. But for the most part in the province, care is not well coordinated. There are no provincial standards. I think people are quite surprised when we say that. Rural care is terrifically fragmented. Wait lists are significant. So it was very clear from Peachy's report and followed up by KPMG that we really need to do a much better job of planning. And this isn't about planning, and people think this is all about saving money. It is about being fiscally accountable. So we have not seen cuts, but we've certainly seen redesign, and you will see that continuing. And we've also seen reallocation where we have saved money. We have already started seeing some reallocation. So you heard that we were putting more money into the hips and knees. That money was not all new money. It was actually a huge portion of it was through cost savings. Things like decreasing the numbers of prostheses we purchase in this province to really focus on the best and the most efficient, and then new contracts. So in fact, behind those additional hips and knees was not a big pile of new money. It was a whole redesign. So how have we gone around this planning? There have been 11 clinical teams put together, And the most interesting thing and rewarding for me personally was the makeup of these teams. These were tight, small teams. They were consulting with other people. Cheryl's been on the child health one, but these were not Winnipeg teams. Each of the SDOs were asked to send in names of people, and we worked really hard to make sure that we had about 2 people from each of the service delivery organizations. Now think about that. At the table, that meant that the people with the lowest population numbers still had an equal voice. And it truly changed the conversation for all of us to think provincially. Every team also had Indigenous representation. And I should tell you, when you look at these teams, that cross-cutting all of these teams is an Indigenous team. And that team is also working with our First Nations folks. There's an ICT or e-digital, used to call it e-health, crossing all of these. Lab diagnostics crossed all of these. But these folks were really asked to sit down, not talk about what's happening at the service delivery level, but actually talking about redesigning the system. So I think that's why I was trying to describe to Jesse, no, I'm not going to come and say, and here's what's going to happen on June 5th. And this was about how are we going to work differently together? Huge common themes started appearing. We are not capitalizing on the use of information technology in Manitoba. It's not just about telehealth, it's about e-consult, it's about e-referrals and so on. We are not making sure that people have access to special care. That does not have to mean coming to Winnipeg. The costs of transportation are remarkable. And if you hear the stories, people traveling on a bus for 9 hours, most of that is gravel roads, getting on a plane, coming to Winnipeg for a 15-minute appointment, only to find us canceled. So hearing the patient stories really forced us to sit back and think this through. Well, all of that clinical planning's been going on. I've been leading a group that's been talking about quality because so many people have felt this is all about money. Yes, sustainability is important, but the real reason is quality. All of those reports, wait time reports, Peachy's reports, standards, inconsistency, is about quality. So I put together a team and also a lot of support from, you'll hear the word TMO, that's a Transformation Management Office, that is provincial. It has project management resources, so all of this is project managed down to the wire. That office is accountable to TLT, the Transformation Leadership Team. That is chaired by the Deputy Minister and has representatives from around the province. And that is a decision-making body which is also directly accountable to central government. So this isn't a little project that will go away. This is directly accountable to Treasury Board, to Premier's office. So we truly are tracking all work. Some of us were determined that in Manitoba, we don't define quality the same way. And if we are going to do everything through a quality lens, we better come up with a framework. I'm sharing this with you. It's been approved, but we haven't done a formal launch. But as you've all been touched by accreditation and so on, we sat back and said, it is time to make sure we're all talking big picture quality. So you will notice here that there are 10 dimensions of quality, not 8. So those of you who are familiar with Accreditation Canada are used to 8 quality dimensions. So I will point out that we have approval to add 2. One is workforce. So that's over and above work life, but we must pay attention to workforce. We've got some real hotspots in the province where we don't have staff, or could we be using staff differently? And the 10th that's being added is equity. And this is really going to now force all of us to think about quality is about equity, it is about efficiency, and so on. You will see that the framework has 4 quadrants. This is the IHI, used to be triple aim, now quadruple aim, where what we've tried to do, and we heard from staff, so quality is board to ward. That's the sort of terminology we have to resonate with all folks. And you'll see those 4 quadrants. So what we've been trying to do is to make it understandable. And I can tell you, as we're moving forward with accountability, so Manitoba Health's role in all of this is changing. All organizations, so the regional health authorities will now have commissioning letters. And it will no longer be, here's a bunch of money, tell us how you do. There will be clear accountability measures for the dollars spent. Again, you're so used to this with organizations, and I'm thinking of Rehab Center for Children, with service purchase agreements. We've always looked at fiscal as well as performance measures. That hasn't been the case for the rest of the system. By coming up with a quality framework, we're really pushing forward that accountability cannot just be about dollars and the number of visits, that we should be looking at all of the domains of quality. We're bringing these 2 together. So the other high level thing you should know is, out of all the planning, those planning teams, perhaps with some modification, will likely be evolving to be clinical networks. In other words, the other thing we haven't had in Manitoba is clinical governance. If any of you are interested in clinical governance, you can look this up. But around the world, there are clinical governance structures. And what is the role of clinical governance? Is quality. So instead of standards committees being hospital-based, many are moving to become provincially based. And it's those standards committees are moving much more to clinical governance will align. So now I'm just pointing out that as those clinical governance teams start looking at not just the plan, but what are the expected outcomes? How are we going to measure how the plan is rolling out? Here's the framework that will be used. So you're starting to see this come together. My last comment, and we can open it up to questions, is that people think the clinical planning is actually the project. So I am going to really encourage you to, it's probably easier to Google it, just Google health transformation in Manitoba. You will see a blueprint, and it's a grid with all the projects. We have just finished wave 1. So just to give you an example, wave 1 of all of this transformation has been the clinical plan, which will be submitted to government by the end of spring. Government will take a look at it, and before anything then is announced, they need to approve or see if there's any other input. So expect to hear more details in the fall. I can tell you with that project that the clinical plan has got a high-level model that is talking about really 4 hubs. The first being a local hub. So clearly in all the planning from all those teams, it's clear that we need to make sure there are local hubs of healthcare. Those would be predominantly community services, integrated community services. So primary care, home care, public health. Then we're talking about what kinds of services should be at a district level. So should every district in Manitoba have an emergency room? And how do we make sure that when we're talking emergency rooms, you know you're guaranteed a standard of service at an emergency room, and it truly is 24/7, 365. It's not Tuesdays and Thursdays. So how do we bring that together? The 4th major hub that they're talking about in that model is an intermediate hub. And I would liken intermediate to being our community hospitals, Thompson, the Paw, Brandon, and so on. And the outer ring will be the provincial hub, which really is those highly specialized services. so health sciences and others. So you'll begin to see some of that being talked about. But truly, the provincial plan is that high a level and saying, okay, we need to rationalize around those and start setting standards for access. Other projects that have been in wave one has been all of the consolidation of the diagnostic services, the transfer of health science centers. So that sounds easy, not. So, rechanging all of the financial structures and so on. The quality team has been another project. So there are just many, many projects. And like I say, go to the website and take a look. So shared health is an enabling tool, but the projects are many. So it's not just a clinical project, it's all these other pieces. With information technology, e-digital or what was e-health is now also shared health. It's no longer WRHA. And that's really important, particularly as we're thinking provincially. The benefits of IT clearly have to be provincial. So wave two is starting this week. Issues related to call center functions, some of the ongoing changes, the mental health reports and so on. So you will see all of these up on the website, and you can actually see the amount of activity going on. So I wanted to really leave you with, here's shared health, 9 people, and now we've got the other operations, but the real big piece has been coming up with a model to rethink the health system, and really focusing also on tightening up the provincial pieces and really explain to you that transformation is much more than the clinical plan. There's a lot of other changes, the logistics, the capital planning. And if you think about it, every region has capital planning issues. And we're waiting for the clinical plan. So before we refurbish an emergency room in rural Manitoba, will it be an emergency room or will it be an enhanced primary health center? And before we change hospitals in rural Manitoba, if it's a 14-bed hospital and the average length of stay is 500 days, is that a hospital? Or should we actually be refurbishing it to be a transitional care or long-term care? Like, how do we actually do better for the people we're serving? So I'm aware of time, and I'm sure there's questions. So I'm more than happy to come back in the future, say, okay, here's where we're going next, and give you much more detail. But I thought I should start up here so you understand who we are, and I want you to know you are part of shared health. I mean, shared health is shared health. Yeah, no, well, that was a stretch. Sorry. I thought, So any questions or comments? I really have kept it high and systemic. And as soon as Jesse told me you all wanted to know what was going to happen to you, you must stay the leaders. So what's going to happen to you? You've done it. God only knows. I mean, all Sky Point is we've gone through so much change. But we also took 17 years to do it. This change, I don't think you're going to see all the changes completed for probably 5 years. This is major, and we need to really go at this in a sensible way. Yes.
One of the questions I have is, how does allied health fit into the planning of shared health services, particularly in relation to the work that CTI is doing, and also some of the other work that some provincial groups are doing, like the audiology working group or for the NHS program. I think there's a lot of questions for allied health professionals, particularly with HSC. There are a lot of outpatient departments that function in cooperation with WRHA. We're not getting a lot of information back on that, and I think it's a little unsettling for a lot of them.
So the question for those who are on the webinar is what's happening to allied health with changes going on at HSC, but they coordinate with WRHA. It's unsettling to not have any information.
CTI.
CTI, exactly. So that's really getting into the details. So I want you to know it's on the radar screen, but nobody's planning at that level yet. But let me just go back and being allied health myself in my previous life, allied health has been included on all 11 of those provincial planning teams. But again, it's being high level. I've sat in on the rehab group as well. And we've been talking about access, like we've been way up here saying, well, what allied health, what restorative rehabilitative services, including speech language and others, and I'll say psychology as well, has been very important on those teams. We have unbelievable inequitable access. CTI has been chipping away at this for years, and so CTI is on the table that we need to now start looking at the work that CTI has done and how do we actually capitalize on that. So if you're looking for details yet, we're still way up here. The CTI question has come up, so it's we've noted that so Deloitte's actually helping write the report. We have called an initial meeting with some allied health folks from across the province, so it was not about Winnipeg alone, and really started planning. So we have mapped out all allied health positions in the province. Now you'll start seeing inequity. And then the question about health sciences and so on, if we in fact are confirming, and so this is all going to government, saying here's what should be provincial, here's what should be at the intermediate level district, what does that look like in the end? So things will be staying the same right now until that high level sort of thinking is done. But allied health is very important. Helen Clark is the Chief Allied Health Officer. And the other piece that's included in this, which is another big piece, is fire paramedics. And not just fire, but let's just talk about paramedics, paramedic medicine, and where does that fit in? So I want you to be reassured there are tables, they've just started. CTI is clearly noted, and we've had conversations with government so that it's being brought in, but we're not into that detail yet, so stay tuned. So it's not that it's not being considered, it'll be that next conversation. And allied health is very important, and I can also tell you, I think we need to think even bigger. So at what point do we start introducing the principles? CTI is one piece of the puzzle, and then there's the whole puzzle. So I'm going to suggest in many areas of the system, and particularly in our acute care and so on, we've lost sight of restorative care. And we do know, and so I'm working with the university, we've got a major piece of research going on right now that was funded through RADI in looking at what is community rehabilitation, what is restorative care, who knows, this is complicated, but what are the models? So let me give you a really, it's the other end of the age spectrum for you. With the introduction of Priority Home, which was that intensive home care to make sure people were not staying in hospital and then becoming ALC, but getting back home with enhanced home care, including rehab. Did you know that as of today, we have about 160 empty personal care home beds? So we institutionalize people at a higher rate than any other province. And I'm going to say that's because the lack of that approach and maximizing allied health and restorative care approach, our pendulum had swung to institutionalizing, doing for people, not with. So all of that's on the table. And it'll be very helpful. The piece of research we're doing should be done any day. Yeah.
Everything is really big picture, will there be avenues or ways for staff that are more frontline to ideas? I definitely respect that you have big groups and provincial, there's so many things that you think about what specific plan is, but I think sometimes there's some really innovative
Absolutely. So the question is, will there be ways for staff to have input and have a voice? And I want you to know, staff always have a voice, and we need to move forward. So I'm going to again use Sky as the example because she's been ahead. I mean, change management was key. We had staff forums, and I'm going to say we also had family forums. So I think we are moving beyond patient and public engagement to patient and public involvement. So yes, this is high picture. People who have been on these teams have communicated with folks. We're in a stage now where we're looking at stakeholder engagement. So what do we mean by stakeholder engagement? So we have more than 1 million people in Manitoba, and I'm going to say all Manitobans need to have an avenue for a voice. We've articulated engagement, and we're using IAP2, which is the International Association of Public Engagement. We're using that methodology so that we're clear about engaging who for what. So there are different forms of engagement, one being communication, the next being feedback, the next being joint planning, and the next being community ownership. So we've got adoption for that, for all of this, and we've identified well over 1,000 groups for stakeholder engagement. So this first piece, we're right in the middle of that. So that includes the municipalities. So your mayors are most concerned. Are you closing down my emergency room if you think their hospital is their economic driver for a town that has one gas station left? So we're being very careful. All of the provincial regulatory bodies. Last night I spent a couple of hours with the Manitoba Association of Community Health. So we're beginning to take out some of this initial work and jotting down some of the ideas, and I will certainly take back the allied health as a reinforcer. Then what happens? We need to wait for approval from Manitoba Health for component parts, but the service delivery organizations are the operators. So that's where we need to work with all of the regions and see how all of this plays out, because that staff engagement has to be at the local level. And if you look at all the other provinces where they centralized and nobody had a voice, the quick realization was we need to actually figure that out. So I don't want anybody to think that the provincial planning is doing about what we're trying to do is set the frame. And in the middle of all this, also Manitoba Health is fundamentally changing its role. You'll see what used to be all the branches of Manitoba Health are gone, and their role is now one of policy. So I think in all of this, Manitoba Health needs to figure out what does policy mean. Shared health is not there to dictate what service delivery organizations do, but to facilitate the planning, the standards. But all of those service delivery organizations are still accountable to government, not shared health. And what we need to do is build in for all those service delivery organizations, there must be staff engagement through and through. So, I mean, I think every so often, and I said this when I first went to the health authority, is that every so often you forget that this is a Titanic in a small port. But I will always hold up Sky as the example of what can happen.
You should be doing planning services here and like building feedback because we have so many provincial. I think we're always wondering how to do that dance. Do we go to the community? Do people come to us? That balance of efficiency of travel versus care coordination. I think you're right, Jeanette. We've done some of this, but now we have new challenges of how do we provide specialized service provincially in an equitable but efficient. And I'd like to hear your comments on where the digital piece is going to go provincially too, when we finally have a digital platform.
So the question is, I'll do the last one first, a digital platform, and then how do you as a group look at some of the efficiencies. Well, we finally have, and I made a note of finally, we have a lot. 1 second. We have a lot. We also have a deficit. So there is no such thing as a system. There is such a thing as we need to pay attention on more connectivity. Our biggest gap is the lack of fiber optics in the north. And so this hasn't gone lost on us. And there's also a need to ensure some more standards. So I'm not saying the work's not done. There's huge work. So there's a new system in home care. It's not quite rolled out. We do not have a system for critical incident reporting that's consistent. So there's many pieces to the puzzle. The dream list is $1 gazillion that we don't have in the province, but there have also been independent projects that have been sucking up resources. So there will be a much more coordinated planned approach to IT. So given that ICT just moved over last week, I can't say that they're all of the plan, but I can tell you there's an enormous plan that has been forwarded to government for years. So it's not as if there hasn't been a plan, but this needs to be thought through and we're going to have to prioritize. I can only tell you that you're in the driver's seat and you're so far ahead. And as you're addressing the issue of efficiencies in transport and provincial and local, there are key principles in my mind. One is real involvement of your communities. You're also crossing jurisdictions, so I think capitalizing on strengthening those relationships and ensuring First Nations input and ownership. So I think as time goes on, there may be efficiencies to be gained on what's going to be more efficient with people coming to a central location based on access to technology and so on, and what can be delivered external. I'm going to say you are the leaders, and one of the key principles that I think you need to talk about more is also about building local capacity. So it's not all about you. It's not all about everybody coming here and you going there. It is about building the capacity and the capability of communities. So you can become the advisor, but not always the service provider. And if you keep those principles in mind, I do think these things will evolve. And I also think the intensity of service going out may be higher to start with as you build capacity with other goals. So I would just keep in mind that efficiency and effectiveness are two dimensions of quality. And if you're doing the best you can and you never see it as stagnant but evolving, that would be my best advice. I'm aware of time. Jessie.
Thank you so much for coming, Jeanette, and we will for sure take you up on your offer of coming back maybe at the end of the year to give another update on what's happening and if we can get more information, or maybe we could even before that session collect some questions from people who are attending so you can have them prepared. So maybe we could plan for the end of the year for that. So thank you again for coming and for everybody for coming in the morning. So next month in May, we will be hearing from the Cerebral Palsy Association in Manitoba. So we'll hear what services they offer and different programs and how you can get your clients and families set up with them and how they interact here at Sky Centre. So I will post the recording of the webinar on our website. So if you want to watch it again, or if you know somebody who wanted to attend but couldn't, then you could send them the link and they can watch it from there. And if you have any more questions for Jeanette, you can either email Jeanette or you can email myself and I'll let her know. And definitely also go onto the Shared Health website to learn more about Shared Health and the healthcare transformation. Thank you very much.